We are at the Right Doctors Com, and I am Dr. Manoria, Executive President of the First World Congress on Cardiometabolic Medicine, and we have with us Dr. Ashok Seth from the Escorts Heart Institute, Delhi. Dr. Seth, acute myocardial infarction is a very common emergency faced by all of us. What is the best treatment in the Indian context? Because in Indian context there are lots of limitations.
I agree. In the Indian context, there are a lot of limitations, especially the patient getting to the right place for the right treatment. Now, there is no question in my mind that if a patient can get to a center which has angiography or angioplasty facilities worldwide, angioplasty, opening up the blocked arteries, putting a stent in is the best treatment. Even keeping the Indian context in mind, where now the numerous government schemes which actually cover practically the whole population in many states, and in many states that's being successfully done on patients. But the real issue in such a situation is no more the affordability issue, which is now most of the population in India is being covered by for something like this, but the availability of angioplasty and stent implantation, though that is moving to smaller cities. So the first line treatment becomes as rapid institution of thrombolytic therapy as fast as possible, and then transfer to a center which can actually do an angiogram and if needed an angioplasty. So this sequence is important. Outlining those centers which can give thrombolytic therapy immediately is important, and outlining those centers which can do angioplasties gets very important, so that the patient knows in a whole state what is near to him and where the best treatment is going to be available. So it's a continuum of treatment rather than one or the other. The second aspect I must emphasize is that even in thrombolytic therapy, we in India at the moment are using streptokinase. That revascularization rates of streptokinase are low. We know 40% only people revascularize. Better agents which are now being made in India and at a less and are less expensive than they used to be, like fibrin specific agents like TNK, tenecteplase, can actually be used and are 80% efficacious, and I think that's where the whole process should be. We should be able to create a system of continuity, state by state, hospital by hospital, to help our patients have thrombolytic therapy and angioplasty.
The other problem in Indian context is acute myocardial infarction is not only rampant, it's occurring younger and younger age. We now see myocardial infarction occurring even below the age of 30, sometimes between 20 to 30. What is difference in these young myocardial infarction compared to the old, and how can we minimize the young infarcts incidence?
It is very worrying, and majority of the young infarcts develop heart attacks related to thrombus formation on a small vulnerable plaque. So these are not blockages which are 80 and 90% like elderly, which suddenly go into a heart attack. Even minor atherosclerotic plaques of 20 and 30 and 40% may suddenly rupture and actually cause. And that's what happens in young people, and that happens because of their bad habits in a sense. High cholesterol levels, obesity, heavy smoking is one of the predisposing factors to soft plaques which rupture and cause thrombus formation. Inactivity, perhaps even pollution is contributing to it, and we know that coronary arteries, endothelium of coronary artery gets damaged with pollutants. So we are looking at a whole spectrum of changing habits for the worse, which is affecting the young individuals, and they are getting affected by heart attacks. These heart attacks are even more severe than the elderly. I must also point that out. The younger people get more severe heart attacks because they don't have any collateral channels to support them. We have to be very cautious around this, and we've got to inculcate good habits right from the beginning to prevent this growing menace of large, severe, life-threatening heart attacks which are now happening at the younger age group.
We have several advanced cardiac centers in India now. What is the mortality of acute myocardial infarction the patient presents within the window period, and how early he can be discharged in the current era?
So the mortality of acute MI has gradually decreased over the period of time from a 10% zone, 15% I would say 30 years ago, to a 10% hovering for quite some time in the 2000s, to now down to 4 to 5%. And that's essentially because of the advancements in every aspect of the technique. So we've got better drugs, better lytic agents, we have better primary PCI and better schedules, we have better agents to actually help them in hospital. But in addition to this, what has been worked upon to decrease this mortality is the continuum of care which is being emphasized again and again. It is not a care provided by X or Y. It is a care provided by the primary physician, which transfers on to a clinical cardiologist, which transfers on to an interventional cardiologist, and again back to clinical cardiologist, which improves the patient care in a manner that his mortality remains the lowest. So, it is not one or the other.
Dual antiplatelet therapy is an integral part of management of acute myocardial infarction, be it medical treatment or be it angioplasty. Now, what are your take-home points? How long it should be continued? Which dual antiplatelet agent should be selected in addition to aspirin? And is the duration of treatment different in patient treated only medically and patient treated with an angioplasty?
Right. So, that is a very important point. The dual antiplatelet has been traditionally aspirin and clopidogrel, but it is now quite clear that the new P2Y12 inhibitors, new antiplatelet agents like prasugrel and ticagrelor provide advantages or superior advantages beyond clopidogrel therapy. However, they are expensive agents. So, for a routine clinical practice, I would say that clopidogrel and aspirin offer great advantages and have been known to offer these great advantages up to a period of 1 year after a myocardial infarction, provided the bleeding risk was intermediate to low. And so, dual antiplatelet at the time of presentation of a patient, the patient can be given aspirin 325 milligrams crushed and non-coated aspirin and clopidogrel less than age 75, 4 tablets straight away. And then if the patient has thrombolytic therapy, it is a different aspect, but if the patient has a stent implantation, that we must remember may not be clopidogrel. In fact, it has been shown that ticagrelor and prasugrel, ticagrelor may be actually superior to giving clopidogrel and has better effects and better outcomes over a 1 year period. So, here is the triage as we would see it. If a patient was going to a center which was going to thrombolize a patient, the patient should actually have clopidogrel loaded at that time. The new P2Y12 inhibitors, ticagrelor and prasugrel should not be given with lytic therapy at least for 48 to 72 hours. However, if the patient went to an angioplasty center, then he would be loaded with ticagrelor before going to the cath lab, or in cath lab prasugrel after the angiography has been done, and then dual antiplatelet therapy after stent implantation would be continued for a duration of 1 year, or in patients with high bleeding risk only to a 6-month duration, and then shifting to clopidogrel and not prasugrel and ticagrelor after 6 months duration.
Metallic DES we are using in acute myocardial infarction for so many years with very good results. Now, there is some controversy regarding the BRS. So, what is the final stage at which it is? Because some of the companies have withdrawn the absorbed stent.
And on the other hand, yes, there have been concerns regarding bioresorbable scaffold, and the concerns did not relate to its efficacy. A very advantageous device theoretically which disappears in period of time, leaving a nascent artery with the healthy endothelium, which may never have a problem later. So, it gets rid of those disadvantages of a lifelong foreign body. On the other hand, the issues related to its thrombogenicity, increased thrombogenicity as opposed to the present thin strut latest generation of metallic stents, a very difficult device to beat. So, at the moment, the clear thought process is that the old device was a first gen device, needs to be modified further to make it safe, and the first biggest modification is going to be in thinning it down in a manner so that endotheliizes well, it becomes less thrombogenic, and therefore, the safety issue also gets covered. And by the way, it is out from the first generation devices out, but at the moment 24 companies are working on thin strut bioresorbable scaffolds, and even an Indian bioresorbable scaffold has been developed, which we have put into trials as mandated by the regulatory authorities of India, and I was privileged to be the principal investigator. The device has shown to be beneficial, and it is approved in this country and many of the countries across the world, and is CE marked. So, the future, I would say, is that the second gen device is a modification of the first one, meant to improve the safety, decrease the thrombogenicity, and therefore efficacious we know it has been. So, I think we are now getting closer to the safety and efficacy of metallic drug-eluting stent without having a foreign body implant for the rest of our life.
So it is out of sight but not out of mind.
You are right. It is out of sight but not out of mind, and maybe soon in sight in the years to come.
Now, there has been great advancements in angioplasty. So, what are subset of patient at the present state of time, or there are any subsets which cannot be tackled by angioplasty, or you have won the battle of coronary artery disease?
I would not say that this should be considered as a battle, because over the period of time, we've realized that both bypass surgery and angioplasty have had and presently have their advantages, and there's certainly what has certainly come out to be that greater and greater trials have shown that as drug therapy has advanced, as the stents have improved, the results have grown so durable and reproducible and reliable that in majority of the instances, the indications of surgery have gradually transferred into angioplasty, and that's been seen for triple vessel disease, that's been seen for left main disease, and the recent trials of left main again demonstrated a non-inferiority of stenting to surgery. So we're looking at, so I think what we're saying is that extreme complex calcified triple vessel diabetic anatomy is still perhaps does better with surgery, but in most instances 75% of the patients are doing better or equally as good with stent implantation. So we still have to individualize it to the patient, we still have to accept the fact of their finances, of their whereabouts, of what their personal preferences are, but it's quite clear that stenting is a more viable and safe option in most instances than bypass surgery.
Then are there any unresolved issues in coronary artery disease at the present state of time?
Oh yes, I think diabetics is a huge population. It exists in 30%, 40% of our patients. It's an unresolved issue. We still need to define how to actually get most durable results with diabetics, especially with diffuse disease and multi-vessel disease. I think that's an unresolved issue. Heavily calcified and unfavorable lesions are another issue. But then I think quite often what's happening is that we are tying up very closely with the surgeons, and there is one issue where gray areas will always exist. So for example, left main, at least it's becoming clearer that angioplasty is non-inferior apart from need for repeat revascularization. And so emphasis goes on, can we actually firstly make it even more durable than it is at the moment? It's safe, it's effective. Can we make it a durable option? And secondly, can we actually get rid of an implant, like I say, bioresorbable scaffolds? Why have this permanent implant forever if we can actually restore our arteries to a nascent situation? A good hypothesis which may provide advantages in the long run of not having delayed restenosis or thrombosis of events. And perhaps that may be the day if we can prove the long-term benefits of a resorbable scaffold over a 10-year horizon, then science would change to actually say, let's give a stent in and then not have anything left behind in the coronary arteries returning to its nascent stage.
Lastly, why preventive program is not on any large scale in the Indian context? The politicians also die, the bureaucrats also die of acute myocardial infarction. Why is not being implemented?
It is the most important thing, and I think I can only understand this by saying that if only we could actually have a robust preventive programs, the financial implications of treatment would go down. At the moment, people are suffering because they have to pay heavily out-of-pocket expenses for treatment of coronary artery disease. We should be talking about prevention far more often. We should be instituting far more often. But on the other hand, let me also say that prevention is in every human's hands. It doesn't require huge legislation. It does require some policies of smoking, etc., and fat food, diet. But actually, prevention of heart disease for myself is in my hands. If I exercise regularly, if I make sure that I don't smoke, I control my diabetes well, I get my blood pressure checked well, I eat the right amount of food, I do a healthy living, and I walk every day 45 minutes, I would be decreasing my heart attacks rate by 30% anyway. And that's what we're not doing to ourselves. So I believe as a nation, we need to start understanding that we've got to be proactive and not counteractive. All our patients always say that अब तो हमने चलना शुरू कर दिया after having a heart attack. All of them say कि इनके लिए तो अब मैं special खाना बनाते हैं कि ये एकदम fats न खाएं. Actually, many of those should have been done before rather than after the heart attack.
Enjoyed the pleasures of experience.
Thank you.